Hello, everybody. Thank you for the very kind introduction. My name is Hilmi Ismail, and I'm a consultant staff anesthetist at the Peter MacCallum Cancer Center. I also co-lead the CPX lab, the prehab service, and the pre-anesthetic assessment services at the Peter MacCallum Cancer Center. I'd like to start with acknowledgement of the traditional and aboriginal owners of land on which we work, the Wurundjeri people of the Kulin Nations, and pay my respects to their elders past and present. I'd like to also start by acknowledging the work I'm doing with the Center for Digital Transformation of Health as a LHS Academy Fellow. I'll start my presentation off by just giving you a quick summary of what I'll try and take you through. We'll talk about essentially the Anchor project, which is this project I'm doing in the context of the LHS Academy Fellowship. But I have a few slides that I'd like to go through with you on the concept of prehabilitation, a bit of evidence surrounding prehabilitation, and how we practice prehabilitation and incorporate it in our clinical workflow at the Peter Mac. I'll take you through a case history of a patient who goes through this service, and then we'll try and figure out what the problem is we're trying to solve with the Anchor project. We'll quickly go through the learning community, a few details around the learning community that has been created around these LHS projects. And then I'll spend the last few slides going through the Anchor project, describing it, and also discussing some of the challenges that we are going to face. So I'll start with the definition of a learning health system. It has been defined as a health system in which internal data and experiences are systematically and that should be iteratively integrated with external evidence, and that knowledge is put into practice. A lot of you would have seen this learning health system life cycle diagram, whereby the data that we collect in our everyday practice is converted to knowledge. That knowledge is then taken and processed, and we then implement it in clinical practice. And then in turn, we collect data from that point onwards. And this cycle in an LHS kind of framework is a cycle that will repeat itself and keep refining itself. So the focus of a learning health community, which is the community that governs these projects, is on collecting data to generate knowledge and applying it to improve practice by informing deliberate processes or by directly feeding decision support systems. So some of you might be wondering what an anesthetist is doing in the middle of all of this. After all, it is to do with the wider patient journey, and also to do with a whole lot of computing and health informatics. And the answer to that question is that I am also a perioperative physician. And one of the goals of perioperative medicine is to reduce postoperative complications, to reduce inpatient hospital days, and also to reduce early hospital readmission rates. So the problem that we kind of encounter trying to achieve those aims is that we really lack very good decision support systems that are driven by our locally derived data. And the operative word here is locally derived data. So what is prehabilitation? It's defined as a process of enhancing an individual's functional capacity before scheduled surgery, and it's aimed at improving the patient's tolerance to upcoming physiological stress. In other words, it's an attempt to build up redundancy, physiological and psychological. As you can see here, the solid line in gray is the standard care line, and very often patients who have a surgical insult, they have a drop in their physiological reserves. Occasionally, that drop is below the functional minimum and even the survival minimum, which is that red line there. Patients who do survive, which thankfully are the majority, they slowly recover their functional capacity, but very often they never really get back to where they were at baseline. And the aim of prehabilitation is to try and lift that trajectory up so that nobody falls below the mortality line there, and we have a minimal number of patients falling through the morbidity line. So this is some of the evidence around prehabilitation. It was a systematic review and meta-analysis that we did a few years ago. Unfortunately, most of these studies are fairly small, but they were able to show that as a result of about a 6-week comprehensive structured prehabilitation program in patients having abdominal cancer surgery, it is possible to improve functional capacity as measured by the 6-minute walk test and the peak VO2, which you see here, and also reduce hospital length of stay and complications, particularly pulmonary complications. These are the sort of almost classic studies now that we look at that show a very strong signal for prehabilitation. The first is a UK study, 124 patients who are having AAA surgery, so fairly high-risk surgery in a high-risk group of patients, showing that as a result of a prehab program over 6 weeks, they were able to drop their complication rates after surgery by 50%. The Spanish study here was done on mainly abdominal cancer patients, and the number here was 144, again, a randomized control trial, showing once again that from the intervention of putting patients through a prehab program, you can drop your complication rate by 51%. The study here is a North American study. It was a propensity match cohort, and they were able to show that as a result of putting patients through a prehab program, they were able to reduce savings to the tune of about $22,000 per patient who was put through their program. And then closer to home, we have a study that was done by Ian Thibauden and Linda Dennehy and her group. And here they were able to show that a very focused preoperative exercise program for lung exercise was able to reduce respiratory complications after surgery by 50%. What you see at the bottom there are 4 large multi-center international trials. The first one is actually not a trial, it is a service report. But there's another one from the UK, and then a large study that is currently underway in the Netherlands with a colorectal surgeon. And this is a study that we are doing at the moment with the RPA in Sydney, looking at a community-based exercise program in patients having major cancer surgery. The results of these studies, except the first one there, have not yet been published, but having spoken to the authors recently and the primary investigators of these studies, it looks like the signal is in favor of a prehabilitation. This Greater Manchester study here, which was really a cohort study of their patients over the course of a few years, was able to show a reduction in length of stay of 1.5 days to 2 days in patients who are put through their program. So this is what our workflow looks like at the moment at Peter Mac. What you see here at the top left of our screens is the point at which patients enter the surgical service. They see our surgeons in the surgical clinic, and what you see on the top line there in blue is everything that is done to these patients while they are awaiting their surgery. Very often they go through a battery of diagnostic tests, tumor staging, MDTs. They often come back to surgical clinics, And on average, they spend a fair number of days undergoing all of this, not to mention the neoadjuvant treatments that they go through as well, before they actually get to theatre. And what we have nowadays is a very early way of picking these patients up and doing their assessments, risk stratifying them into basically 3 categories. The low-risk patients go straight to surgery, whereas the medium and high-risk patients are put through our fit for surgery program. Quite a lot of them have cardiopulmonary exercise testing, and quite a few of them also attend surgery school, before which they, after which they attend the pre-anesthetic clinic, which is usually much closer to the date of surgery, and then proceed on to their onto their surgery. This is a helicopter view of our service. We have a cardiopulmonary exercise testing prehab clinic where patients have a comprehensive medical review and go through medical optimization. Coach is our combined outpatient health, allied health service, which comprises an exercise team, a nutrition team, which is to do with dietetics, and we also have a clinical psychology team that sees these patients. This is an area that requires a lot of resourcing, and it's the theatre planning and coordination team, and we work very closely with them. And then there is the surgery school, which is what concerns with patient education, run as webinars every 2 weeks. Overlapping all of this is our ERAS program and the shared decision-making service, which is a fairly new service. And these are the individual interventions we have in the prehab service. Like I said, specialist referrals, often to cardiologists, endocrinologists. We also do a battery of tests on them. When they see their nutritionist, they often get supplements, and with a special focus on whey protein, that is protein supplementation. This is the patient education component that patients are put through. We also treat patients for iron deficiency anemia, send patients to the quit service who want to and can reduce smoking prior to surgery. We screen patients into our psychology service, which deals with issues like motivation, anxiety reduction, and eliciting values and goals. And then recently we've been joined by a rehab physician as well, who is concerned with issues like discharge planning and putting in place communication strategies with the community after patients are discharged from hospital. But underpinning all of this is the exercise component, which comprises aerobic exercise, resistance exercise, and pulmonary exercise. We are governed by a center and steered by a prehab steering group, which consists of senior staff. There's medical staff there, there's allied health, the head of allied health, and all the departments, and also the head of clinical psychology, and we have nursing representation as well. And we break ourselves up into these working groups in order to implement the service. So I'll start with this story of Helen. Helen is an 80-year-old lady. She's from Aubrey. She is a smoker. She leads a sedentary lifestyle. She has type 2 diabetes. Her hemoglobin's 100, bit anemic, and also her nutrition is not the best. She completed her chemotherapy 4 weeks ago, and she has diagnosis of esophageal adenocarcinoma. She is presenting for an Albert-Lewis esophagectomy, which is one of those very high-risk surgical procedures, as we know, that we undertake at Peter Mac. In terms of her social situation, she lives alone. She's independent at this age, and she does get once a week help with house cleaning, etc. She has a very supportive daughter who lives close by with her family of her own, and she is very keen, this is Helen, is very keen to avoid being a burden to anybody, with an expectation to see a great granddaughter be born. She has good decisional quality and good goal congruence with the rest of the team. And the decision is made that we will offer surgery to her. Fortunately, her surgical team decided it was a good idea to send her really early to the Fit for Surgery service. She had a cardiopulmonary exercise testing prior to her neoadjuvant chemoradiation therapy, and that was the basis on which we decided it's a good idea to go ahead with surgery. And she was also invited to surgery school. On the clinical frailty score, she'll probably score a 5. And this definition usually covers the mildly frail kind of patient. So Helen was put through our quit referral service. She was given a quit referral and put through the quit service. She also undertook a focused, structured exercise program with help from a team of exercise clinicians at Aubrey. She also saw a nutritionist and had a dietetic intervention in the way of protein supplements. We also had to adjust her diabetic medications. We had about 6 weeks to do that. She had an iron infusion to address iron deficiency anemia, sorry. And she was also invited, like I said, to surgery school. And we invited her to a series of shared decision-making meetings. And it was decided, like I said, she had good decisional quality. She was also referred to a social worker to try and plan for some support services once she returns home. All of this was done within the period of about 6 weeks. And at the second appointment she had with us, we measured an improvement in her peak VO2 on cardiopulmonary exercise testing. She had about a 70% reduction in smoking. Her HbA1c was optimized, her diabetic management was optimized, and her hemoglobin had come up to 130. She herself was feeling much better, and she had an improvement in her quality of life scores. So key to all of this, as you will understand, was that early referral to the Fit for Surgery service. She then goes through her surgery, which was an Ivor-Lewis esophagectomy. She has an uneventful post-op course. She was discharged on a declining regime of pain medication and required a bit of social support services at home. She spent a total of 10 days in hospital. So having gone through the story, you might conclude that we really don't have a problem. And this is reinforced by some of the statistics that we have from our service for the last 18 months. As you can see, unfortunately, only half our patients were referred to the service, but those who did had a median length of stay of 18 days versus 21 days for those who were not referred, and a similar trend in the intensive care unit stay. So on the surface, it looks like we really don't have a problem here. But if you delve a little bit deeper, there is an issue that we really need to address, and that's put in those 3 red boxes. The first box is a big box here, and that is this decision as to how intensively we put our patients through the program and whether we put patients through the full program at all. At the moment, that is a heuristic decision. It's often based on data from other centers, from other countries. So we're looking at risk calculators that have been devised in North America, for instance. And it is not based on our local data. It is not data-driven. It is more rule of thumb driven. And then, of course, we have this issue of those who are referred to the service having a combination of high to low risk. Similarly, those who don't get referred seem to also have high-risk patients who ideally should have been referred to the service. Another issue that we do have is a significant amount of variation in our outcomes, which is demonstrated by that standard deviation there. So the solution to this problem that we're looking for is rather than have that rule of thumb driven decision at this point, it is to come up with a data driven. So the data is local data predominantly, but data driven system of risk stratifying patients and then having a clinical decision support system that allows us to only put high and medium risk patients through these interventions, which can be quite expensive. The low risk patients then get put through what's known as universal care, and that involves basically giving them really good education using a platform like a webinar. The aim is also to try and get 100% referral into the service in order to facilitate all of this, and then aim for a reduction in length of stay below what we have at the moment, and most importantly, try and reduce the variation in care. So we reduce the amount of standard deviation in terms of the outcomes that we are achieving as well. So in order to do all of this, we really need a learning community. And learning communities are well established in terms of the concept. But in this, our current context, we define ourselves as a group of clinicians and digital health experts who share a common vision and a common goal. And we believe that by the proper analysis of data collected during routine perioperative care, we can improve our outcomes after major cancer surgery by making data-driven changes to practice. And of course, the outcomes that we want are that we have a consistent influence on reduction of adverse outcomes of after major cancer surgery for individual patients, and thereby improve clinical, process, and patient-reported outcomes. So in order to do this, what we've done is created a perioperative learning community. There's a terms of reference document that has been crafted as well, with a focus on collecting data to generate knowledge and then apply it to improve practice by informing deliberate processes or by directly feeding decision support systems. This is the perioperative learning community that has been put together. Some of you will see your names on this list. Some of you I have spoken to, some of you I haven't yet, I apologize. But I will be approaching you with invitation letters and with some documentation regarding the terms of reference. We're fortunate we've had David Speakman agreeing to be executive sponsor, and we have a very strong academic profile in the learning community as well. So we will break ourselves up into project steering committees, depending on which project we are looking at the moment. And we will look at working groups as well under those steering committees. At the moment, the anchor project is the first project that this perioperative learning community is undertaking. So this is a quick review now of the anchor project working group. The project itself, as I'll describe, is broken up into a number of phases, and we have a working group for the first few phases. There are just 4 of us at the moment in that working group, with an advisory group as well. The anchor project itself is, like I said before, it's designed to be implemented within the framework of a learning health system. The project has got 5 phases, and the intention is to complete phase 1 and 2A in 2022, and the rest of the phases will be, I'll describe those phases and go through the timelines for that as well in a few subsequent slides. And as mentioned, we'll have a learning community working group that will undertake the implementation of these individual phases of the anchor project. So what is the anchor project? We have got the initial phase, which is the phase of setting up in our infrastructure. And during that phase, what we will do is take a pre-published machine learning and deep neural network algorithm. So this is these are algorithms that have been published already in the literature from other countries. We will apply it to a large international database, which we at Peter Mac also contribute towards. That's called the NESQIP database, and it is a database maintained by the American College of Surgeons. The database itself has about 1 million patients, and we will extract the cases that we think are relevant to surgery done at Peter Mac and apply this algorithm and train that database to predict length of stay. Once we have done that, we will take that algorithm and we will validate it against our own Peter Mac data using the same artificial intelligence methods. That's phase 2 of the project. And a part of the data that we will be validating against would be all our other locally held databases, and that includes our own NESQIP database. We have an ERAS database, which is Enhanced Recovery After Surgery. We have a prehab database, which keeps all the information on our prehab activity. And then we have a number of databases that describe tumor biology. I haven't yet looked at genomic databases, but that is something that we can look at in the future. And we will also look at data that we currently hold in the Clarity database of EPIC. Once we've done that validation, we then will come up with what we call a digital phenotype for risk of prolonged length of stay. So in other words, we can predict what a patient's length of hospital stay is depending on the digital profile of the individual patient who sits in front of us in the prehabilitation clinic. And then what we do is we take that knowledge that we've now, the knowledge that we've acquired from our data, and we apply it into practice. That application into practice is basically implementing a clinical decision support system. And what the clinical decision support system does is it'll use the risk calculator that we have already got from artificial intelligence, and we will use that risk calculator to direct patients to the various components of the prehab program. Once we have done the practice implementation, we then need to evaluate our practice. And for that, we will use a step-wedge randomized control trial framework. And the primary outcome in all of this would be lengths of hospital stay. All of this will generate new data, and that data will go through this same process of machine learning in order to fine-tune this digital phenotype. In other words, this digital phenotype will start getting refined as more iterations or more cycles of this learning health system take place, so that over time, we will have stronger and stronger ways of predicting patients' prolonged length of stay. The current pattern of our workflow is like what I described before. The important thing is that risk stratification process that I spoke to you about before is always involving a human clinician. And in the intended workflow, that human clinician will also be always involved in spite of the fact that we will have a machine learning algorithm that comes up with a risk calculator. Once the calculator spits out the risk profile of patients, then we will have a subjective way of allocating resources and putting patients either through the targeted prehab program, a fairly general targeted prehab program, or a universal prehab program. By doing this, hopefully, we'll be able to maintain the same timelines that we have been maintaining for implementing prehabilitation in our current patient pathways. Some of the challenges that we're going to face with the Anchor project, as you have seen from one of the previous slides, the number of stakeholders are fairly large, and that is reflected or reflective of the fact that we do have a large learning community. We have, like I said, clinicians and non-clinicians, and the value of the learning community is the ability for all stakeholders to come together and try and get the program as fine-tuned as possible. There are also very critical dependencies in this project. One of the critical dependencies, of course, is around computing and health informatics. And this is where the associations and the collaborations between the Peter MacCallum Cancer Centre and the University of Melbourne is so important. It's also the reason why having LHS fellows or a body of LHS fellows develop at our hospital is so important. The project itself is quite resource heavy, and the remaining phases of the project, in other words, 2B, 3, and 4, are intended to be put in place as a result of a grant. And at the moment, we're looking at possibly an MRFF grant in order to do this, with or without adding on some level of business case activity as well. And one of the biggest challenges is to make projects like this sustainable. And in that regard, I think it's important that the subsequent phases of this project should be taken over by not just myself, but also other fellows as well. And a reminder to all of those listening that the Learning Health System Fellow does not have to come from one particular craft group. It could be from, from a group of medical staff. It could be nursing staff. We could also have allied health staff, taking leadership in the subsequent phases of this program. I think my time is up, and I'd like to thank you for your attention. But I'd also like to thank the Department of Health Services Research here at Peter MacCallum for this opportunity to speak to you, and also helping coordinate this with the Centre for Digital Transformation of Health at the University of Melbourne. I'd like to thank the mentors on this project, Professors Bernard Riddell, Wendy Chapman, and Kaz Thursky. And I'd also like to thank all the members of the Centre for Prehabilitation and Perioperative Care at Peter Mac. Thank you very much.